Hi, good
You
evening,
in?
everyone.
You in? One, in three, two, one.
Hi, good evening, everyone. Welcome back to our weekly Wednesday webinar. And I'm Dr. Betty Tay with Beating Hearts. We are committed to medical education. And all our webinars are free. We have many kind of topics, all sorts. And we have here with us Dr. Tan. And Dr. Tan is actually a forensic pathologist. So Dr. Tan, do you mind introducing yourself a little bit and tell us how actually you went through the path of forensic pathology, and so that it can also inspire some of our junior doctors on how is forensic pathology like and how to go about it?
Okay. Maybe share my slide first.
Okay, fine.
Yeah. Okay, one moment. Okay. Can you all see my slide?
Yeah.
Yeah. Uh, so I did my medical degree. Hi, good evening, everyone. I'm Tan from Forensic Pathology from Hospital Ipoh. So I did my undergraduate in Russia. I graduate to 2009. I think 2009 or 2010, I can't remember. So while waiting to enter the master program, I did another master in forensic science. So from UK. So after that, I joined the local master program from UKM and graduate after 4 years. So while waiting for my subspecialty training, I did another diploma in legal medicines. And last year, I just complete my subspecialty in pediatric forensic pathology. So my area of interest is dealing with the disease, the illness, the pathology of the children's, infants, and those like infanticide, child abuse. Also is my area of interest also. Yeah.
Oh,
Uh,
sad, huh?
yeah.
What a horrible thing to go through. Okay, go on. I can imagine myself doing it. Okay.
Mm. So should I proceed with my topics?
Yes.
Okay. So yeah, and today, thank you for having me today. So I'm going to talk about the iatrogenic injury. So this topic might be a little bit more interesting to your the clinicians, and so maybe we can learn something together from those cases. Yeah, I'm going to share a few cases.
Okay.
Mm. So this is my outline of my presentation. I'm going to talk about the iatrogenic injury and a few case discussion and a few words about the medical negligence. The definition, iatrogenic injury refer to any consequence or resulting from medical activity rendered by the healthcare professional in which the activity may result in adverse condition. Okay, so this is our classification from the forensic perspective. Yeah, so it can be procedure in nature, for example, surgical or anesthetic complication, or non-procedure, for example, the adverse reaction of the drugs, or miscellaneous causes, or combination of uh, different complication. Okay, so the dilemma. So we know that the increase in the population in Malaysia and of the older people are hoping to increase the life expectancy. Okay, this is the trend right now. And our medical technology also getting better and more advanced, and we are getting more clinical expertise and aggressive, so we can do more things for the patient. Okay, for example, sorry, however, at the same time, it also increase the risk of mortality and morbidity related to the iatrogenic injury. So sometimes we need to balance the risk and the potential benefit for offering certain procedure to the patient, and there's a dilemma to think of whether to treat or not to treat the patient. Okay, so I'm going to share a few cases. Yeah, my cases. Okay, so this is a 16 years old boy who riding a motorbike and allegedly skidded and hit an object on the roads. So he was brought to the emergency department Iatrogenic. Upon the arrival, the GCS was full, the vital sign was normal. For example, there's some degree of tachycardia, the HP was 10. The patient was fully conscious. Okay. Externally, there's an abrasion of the chest and abdomen. So this is the photos. So we can see there's a pattern abrasion over the center of the chest and abdomen. So it means that he impact with something solid on the roots. Okay. Because of the persistent tachycardia and the anemia, and the chest X-ray show clearly and large heart shadows. So I think the emergency team think of the cardiac tamponade. So they decide to proceed with the pericardiocentesis. So just a few words about pericardiocentesis. This is a procedure for fluid aspiration for the pericardial space. So it can be subxiphoid, subcostal, and parasternal approach. Okay, so in this case, they use a parasternal approach. So
Show me again, sorry, they use the parasternal approach.
Yeah.
Why didn't they use the subcostal approach?
I'm not sure why they decide to use the
Parasternal approach.
parasternal
I
approach.
myself never
Yeah,
used
in this case.
parasternal. Okay,
So
because the parasternal approach actually
yeah,
will actually, you know, be very near the left ventricle more than the, and it's safer over the subcostal approach. Okay, go on.
yeah. So they did 3 attempts. So the first attempt was by the ET team, emergency team. So there's no blood. So again, they tried the second time. They got 5 cc of blood. So they are happy lah. They got the diagnosis correct. So yeah, then the third time attempt by the medical got 20 cc. Yes, they confirmed the diagnosis. There's a cardiac tamponade. However, the patient succumbed after the procedure. Imagine that the patient come to you with a GCS full, just become tachycardia and anemia, and after the procedure, the patient died. Okay.
Parasternal approach. Okay,
Yeah.
go on.
So from the autopsy, I can see the puncture mark at the fourth and fifth intercostal space, and there's a bilateral rib fractures and a hemothorax for 400 on the right and 200 on the left, with a hemopericardium 500 cc. So I also discovered there's a circular puncture mark on the anterior aspect of the left ventricle, 2 times 2 millimeters. So there's no other source of bleeding was identified from the heart. So this is the photo of the heart. You can see there's a
Oh,
puncture
so
wound.
big, ah.
Yeah, I think because the heart is still pumping, so when the needle penetrate in, and so it
Oh, I see. You mean like
yeah.
the needle, but the needle, okay, because I do quite a bit of pericardial synthesis, the needle is not big, you know. It's probably it's just very tiny. Okay, go on. Wow, okay, go on. This is shocking.
Yeah, there is no other source of bleeding from the heart that I
Yes,
can
yes. No,
identify.
this looks like iatrogenic because, yeah, okay, go on. Possible.
Yeah, so in my opinion, the initial cause of the bleeding and the tachycardia and
Yes,
the low HB might be due to the rib fracture, the hemothorax.
yes.
So, in a healthy person, in the pericardial space only had contain 15 to 50 cc of the lubricating fluids. So basically, the pericardium is adhered to the heart. So in case of the cardiac tamponade, okay, it's the only with the hemodynamic compromise is the only indication for emergency pericardial drainage. So if without cardiac tamponade, so basically the pericardium is adhere to the heart when you puncture it. So most probably you might go into the heart.
Okay, because this is my specialty, can I ask one, was an echo never done for this patient?
This is an ultrasound guided There is no documentation before the procedure whether they did the echo or not, but all the procedure is under ultrasound guided. Yeah.
So if it's the ultrasound guided, means they use an echo machine, or they what did they use?
And I don't want to mention the name of the hospital, but this is a tertiary hospital lah. So
This is
I
tertiary hospital, so they did it echo guided.
yeah.
Must be, if you say ultrasound and it's echo guided. So if it's echo guided, they must have seen some pericardial fluid. It's impossible not to see. But if there is a pericardial tamponade, okay, and there is a lot of fluid, there may not be a lot of fluid in acute tamponade, because if a fluid gradually, like for example, if it's a cancer patient, and then there is pericardial effusion and it grows slowly, patient then becomes quite, how you call that, tolerant to it, because the buildup is gradual. But in an acute case, a small amount can also cause cardiac tamponade, and patients compromise easily. But if it's an echo guided, if it's an echo has shown, they must document that the echo shows enough pericardial fluid. And there are actually a lot of signs that you can pick up if you are good echo technician to show that this is a cardiac tamponade. And one of the easiest way is the heart is actually dancing in the fluid. You know, they're dancing, they're like dancing, and then there is a collapse during the diastolic phase of either the RV or LV. No, the RA or RA or RV or LA. Yeah. So there is not enough documentation here for us to say that it was or it was not. Okay, you go on. You understand what I'm trying to say?
Yes.
Yes. So that if it's really echo guided, right? Unless the documentation is not well documented, but somebody must have seen pericardial fluid. Yeah. But maybe it's the positioning of the needle or their inexperience to do it, because the easiest way, the best way is actually the subcostal way. Okay, go on.
Okay. So case number 2 is a 19 years old man also involved in the road traffic accident. He also admitted to the tertiary hospital. Upon arrival, GCS full with a stable vital sign and normal HB. So they suspect tension pneumothorax on the left. So they did conduct a needle thoracostomy. Okay. However, patient succumbed after the procedure. So this is a picture of needle thoracostomy. So it was known as the therapeutic and diagnostic procedure. So usually conducted in the emergency condition to manage the suspected tension pneumothorax. So there's a needle inserted in the pleural cavity to allow the escape of the air from the chest to release the tension pneumothorax. Okay. So in this particular case, on a postmortem examination, I did encounter 2 puncture wounds on the anterior aspect of the chest and the second intercostal space. So I also did discover the hemopericardium 450 cc and 5 grams of blood clot on the postmortem.
Wait, hold on.
Yeah.
So it's over the left side of the chest.
Yes.
The tension pneumothorax. Why didn't they put in a chest tube?
So, is it my internet problems or?
I think maybe it's my internet problem.
Okay. Yeah.
Why didn't they put in a chest tube?
So this is the I
So
think
it's
they should.
difficult for you to say. Yes, it's difficult for you to say.
Mm.
But okay, go on. Yes, go on.
Yeah, so as I know, there is no X-ray been done before the procedure. So
Oh,
some more the
wow.
patient is stable. Patient is stable. Yeah, they just don't know why they come out the idea to perform needle thoracostomy. Yeah, in a tertiary hospital, and while the patient is still stable. Yeah.
I
Okay.
think you
Yeah.
watch too much movie, lah, too many movies. You know, there are some movies that they really put the needle.
Yeah.
I think these people really thought that is. You mean this diagnosis of tension pneumothorax was not made from chest X-ray? It was not made from chest X-ray. Can you
Yeah,
hear?
not from chest X-ray. Maybe from the auscultation. But there is no, as I know, there's no X-ray done before the procedure. Yeah.
Oh my God. Okay, go on.
Yeah. So refer to the literature in the pre-hospital setting, lack of adequate radiology imaging. So you have difficulty in confirmation of the tension pneumothorax. So and this study 2001, so which is like 20 years ago. So this incident I think happened around 5 years ago. Yeah. So he concluded that the needle thoracostomy is often ineffective.
Yes.
Okay. So it shouldn't use as a sole diagnostic procedure for tension pneumothorax. So if the patient vital sign is normal, so it's advisable to wait for the X-ray. Yes.
Oh, yes, of course. So the other thing I want to ask you is what gauge needle did they use?
I'm not sure because
I think it's a
I
thin
can't
needle when you
remember
see.
exactly. But what I remember the incident is like I don't know why the is a house officer under the supervision of the medic officer. I don't know. I don't know whether they intend to get the logbook done or something. So they said, oh, let's try do the
Oh
needle
my God.
thoracostomy. So yeah,
Show me the previous picture again where there was laceration over is it the aorta? Is
this is
it?
a pulmonary trunk.
Oh,
Mm,
okay. So then it caused the hemopericardium also.
yeah,
Yes. Actually, the laceration compared to the size of the needle used is quite huge. I think you are right. Like the pumping of the heart causes the needle to slash onto the vessel or to the wall more. Because it's quite big. Okay, we go on. Wow, this is very shocking. Okay.
so case number 3. So 60 years old man, he was kidnapped by unknown group of people. I don't know how many. So he was assaulted and asked for the ransom. And I think the wife paid the ransom and he was left on the roadside. So he was subsequently admitted to the hospital. Upon arrival, full GCS, hemodynamic stable. Okay. So he was diagnosed with multiple rib fracture, right and left pneumothorax. Bilateral chest tube was inserted. She also suffered from close fracture of the left radius. On the next day morning, the houseman discovered the chest tube on the left was dislodged. So then he decided to perform the needle thoracostomy to decide whether to reinsert the chest tube or just close the chest tube. Yeah. So then again, the patient succumbed to death after the procedure.
How did he do this needle thoracostomy this time? Okay, show
Okay,
us.
sorry. Okay.
Okay. Show us the picture.
Okay. So, and it showed
Oh
the
my God, the
extensive
problem
soft
is
tissue injury
you
of the
need to,
upper and lower
okay,
limb. You can see the hemorrhage, or he was tortured by
okay, you
salty
need to
nipple. Yeah.
change slide now because
Okay.
Facebook will block me.
Oh, okay.
Okay.
So again, you can see there's a puncture mark at the pulmonary trunk.
Mm.
Yeah. Same location. Yeah.
Yeah, same location, huh?
So yeah. So when I refer back to the guideline, I think they follow the guideline to puncture the correct region, just like but we can't assume all the people have the same anatomy. The topography might be different. So I think had to perform the procedure caution in caution. Yeah. So in this particular case, how to decide the cause of that? So first question, can a multiple soft tissue injury and or tension pneumothorax causing that? I think the answer is yes. So can a iatrogenic puncture wound of the pulmonary trunk causing that? I think yes also. So why the victim collapsed immediately after the medical intervention? Mm. So the next question, why the victim did not die at other period of time? It is due to the soft tissue injury and the tension pneumothorax. So it's actually why I raised the question. It's commonly that sorry to say, the clinician try to influence our cause of that. I say, why don't you bring the
Yeah,
pneumothorax or
I
soft tissue
see.
injury rather than the puncture wound or the pulmonary trunk or something?
Okay, I understand.
Yeah, so that's why we had need to explain to them. Yeah,
Okay. So can we
yeah. So how to
read this
decide what is
again?
the cause? Yeah.
Okay, can a
Mm.
multiple soft injury or tension pneumothorax cause death? Can, but the patient was not brought in dead. Okay, and the patient was hemodynamically stable in all three cases. Okay, so can the iatrogenic puncture
Yeah.
wound of the pulmonary trunk cause death? Obviously, from the hemo. Oh, can definitely. Why the victim collapsed immediately after medical intervention? Obviously, due to the punctured wound of the pulmonary trunk. Why the victim did not die at any other period of time? Because none of the injury was fatal until the pulmonary artery trunk was punctured. Okay, so cause of death is due to carotid tamponade due to puncture wound of the pulmonary trunk. I agree, even I'm not a pathologist. Okay, we go on.
Yeah. So yeah, when the clinician raised the question, so then I give them an example. Okay, now a patient diagnosed with a terminal stage of cancer. Okay, now the patient is gasping and dying in front of you. Maybe in 5 minutes time, he's going to collapse. So now you take a knife and stab on the heart of the patient. Now what is the cause of that? Is the lung cancer or the stab wound of the heart? So they keep quiet. Yeah. So you know the answer. Yeah.
Okay, good one. Okay,
No?
go
Okay.
on. You got some more example, right?
Yeah.
Oh yeah, thanks.
Yeah.
Very
So
interesting.
now the problem is, yeah, for our side. So who caused the death of the victim? How should we tell the police and the prosecutor? Is the doctor or the kidnapper? Okay, because the charges of murder is death sentence, manslaughter 30 years, causing grievous hurt up to 7 years, and so now it sounds like the death is not directly related with the kidnapper, but maybe indirectly related, yeah, with them. So who caused the death directly in this particular case? So initially, the police and the prosecutor can charge the kidnapper for 302, which is murdered. We can punish for death sentence. So however, now there's an intervene of the dying process, or I cannot say dying process. So the death is contributed directly.
What's happened now? What happened? Oh, record. Okay.
So we'll start back.
Okay.
Speak it in.
Yeah.
In 3, 2, 1.
Okay.
Okay, so and let's continue. So okay, now okay. So by right, the police or prosecutor can charge the offender for murder or manslaughter, yeah, or causing grievous hurt. So however, the death of the patient is intervened by the medical doctor, by the medical treatments. So they feel difficulty to charge them. Yeah, they still can detain the offender and charge them for manslaughter or causing grievous hurt. However, they can't charge them for murder. Yeah, because the cause of that is not directly related with the assault, but the medical intervention. Okay.
Okay. Wait, did they find the kidnappers or not?
Yeah, this can know.
Huh? No,
No.
no, fine. So irrelevant what? But if they were to find the kidnappers and charge the kidnappers, okay, will we tell the truth?
This my pet is I have to tell the truth. So they can go with a lower level of charges so they can win the case. So technically to win the case, at least you give some punishment to the kidnapper. Yeah,
I see. So
yeah,
they will call you to tell the truth. It will be upon you, lah, definitely, right?
yeah.
Okay, fine.
Okay. So now the problem. So you want to charge the doctor or you charge the kidnapper? Yeah, in this particular case.
Okay.
Okay.
So
Yeah.
let's go on.
Okay. So so I will touch a little bit about the complication of soft tissue injury because I encounter, I think throughout my career, I encountered 10 cases. So 7 cases are treated by our medical personnel, discharged and underdiagnosed, and how the patient come back to me in
Come
on
back.
my table. Yeah,
Okay.
yeah. So yeah, I did publish the paper related with the underestimation of soft tissue injury.
Oh,
Okay,
I
if that's you
see.
can look in details lah. Okay, so this is a young man under influence of alcohol and drugs. He just recently broke up with a girlfriend, so he intend to break in the house of the girlfriend. I think he want to do for her. Okay, however, he was detained by the police and admitted to the hospital because he will have some episode of seizure and under withdrawal syndrome of the alcohol and the drugs. So he will admitted under the medical care in isolation ward under the care of the medical, surgical, and PSY team. So on day one, all the blood investigation was normal. Okay, there's no repeated any investigation later on. So by reading through the documentation, all the vital signs were normal throughout the 4 days admission. So there is not active management throughout the day, 4 days of admission. So, okay, on day 4 morning, during the morning round, so the medical saw the patient, okay, they decide to discharge. And the surgical PSY also come and have a look and discharge the patient. So while waiting for all the medication, discharge summary, everything, yeah, around 4 o'clock. So the police enter the ward to open the handcuff, and he was found no sign of life on the bed. Okay, but bear in mind, all the vital sign was normal throughout the admission.
How did they
Okay,
handcuff him? He handcuffed him to the bed?
yeah, because he is under detain of the police. Yeah,
I see. Okay.
yeah, yeah. So this is the this is the chest. This is abdomen. Yeah, you can see. This is the blues. So this is a quite common location. Yeah, if you uh, always watch the police movie, yeah, you know that they like to hit this region. Yeah, hit the efficacy region. Yeah, to cause the pain. Okay, so this is the only thing that I found during postmortem examinations.
Okay, next
And
slide, please. No, so
okay,
okay.
okay,
Sorry.
yeah. So other than that, so the testing of the urine got myoglobin, and the histological examination of kidney also there's a myoglobin. So there's the confirm the diagnosis of rhabdomyolysis.
Okay,
Okay.
sorry, can you tell us where exactly is the injury of the soft tissue again?
Yeah, in the efficacy region.
Okay, so he was punched by whom?
Most probably, yeah, the police officer.
I see.
Yeah, so because the story is not so clearly, okay, so what I know is that he was found having seizure and then admitted to hospital. So, but we don't know that maybe before the admission, they did some interrogation on him.
Okay.
Yeah, so there's an injury encounter, yeah, during the interrogation.
Okay,
Okay.
another question I want to ask you is post-mortem. Can post-mortem wouldn't the blood show hyperkalemia? No.
And the potassium level is always deranged during the postmortem.
Huh.
So
Okay.
even we take the what is it? The RP, even show even the level is high, it doesn't mean that the patient having hyperkalemia lah during antemortemly.
Also, was the potassium high during his stay in the ward?
Yeah, day one is normal, but
Hmm.
they never repeated any investigation.
I
Yeah,
see.
throughout the admission. Yeah.
Okay.
So this is the same scenario for my other 6 cases. So all the soft tissue injury was discharged with vitamin D, the painkiller. After like 2 weeks or no 2 weeks, 1 week of admission, they released the prisoner back to the prison, and then later on they found that in the prison. So they did discover the soft tissue injury, but they underestimate the complication of soft tissue injury. Yeah.
Okay.
So
But
those are the
then
complications.
again, for these soft tissue injuries, right?
Mm.
Other than maybe giving fluid to reduce the hyperkalemia or to maintain hydration for the kidney, you can't do very much, right? I mean, for a
Yeah,
clinician out there, I don't know, you're a pathologist, you only see patients when they are dead. But I'm thinking, right? Soft tissue injuries, it's not like you can operate on them.
yeah.
Yeah.
Maybe you can
Okay.
correct the electrolytes.
You,
Yeah, the
you can
hyperkin.
correct
Mm.
that. I mean, of course, compartment syndrome in certain areas, you can go and release the tension. But if it's at a place where there is no if it's rhabdomyolysis, you just have to wait it out.
Yeah,
Okay, we
maybe
go
that.
on. Oh,
Yeah.
this one I have to think a lot. I'm
Mm. Okay. So yes.
we go on.
Yeah. So the other cases. So personally, I encountered 3 cases of puncture wound of the lung due to the chest tube insertion. So even though the chest tube is a very soft plastic tube,
Mhm.
so if you forcefully insert into the chest, it can puncture the lungs. Yeah, I have 3 cases. So the death most likely related to the puncture wound of the lung, both sides.
Puncture wound of the lung,
Yeah,
but the lung is actually, does it cause pneumothorax or how is it like that it causes death? Because
and the,
it's not like the heart. The heart is actually a solid structure, but the lung is not a solid structure.
yeah, these 3 cases, there are 2 puncture wound left and right side, the chest tube through and through the lung. Yeah, so it's like a stab wound, go in the lung, then they have the
Oh, I
hemothorax. Yeah,
see. So they have hemothorax.
yeah.
Wow.
So when we review back, so one of the case, so there is CCTV record. So the primary thing also allow us to access. So we have a look together. Yeah, the technique. So sometimes maybe the senior doctors they are quite confident really with the chest tube insertion. So that like they insert it very fast and quite harsh. The tool is just punctured both sides of the chest very fast. So they want to show maybe they are very good in inserting the chest tube, but it's how they puncture the lungs. Yeah.
So it was the death sudden?
Sorry.
Was the death sudden?
And
Was it like the one that where the penetration into the pulmonary artery or the left ventricle?
um,
That one was sudden, right? The moment after the procedure, the patient died. This puncture of the lung, was it sudden, the death?
okay, and it happened before the transferring of the patient to the ward. So it happened in the emergency department. So how to call it sudden? So I think
Okay, so
yeah,
not immediately that while you're doing the procedure, the patient passed away, lah. Right? Not like so sudden as the cardiac one.
yeah,
Okay.
okay,
Okay, we go on.
okay. So one case of the embolism of the venous catheter. So this is the
My God.
IBT. Yeah.
Why so many scary cases? Okay, go on, go on.
Yeah. The IVDU patient admitted for sepsis in ICU.
Uh-huh.
So they insert a femoral line for the patient. So the patient was transferred for ICU to the normal ward. By right, they should check all the catheter lah, or pass over to the ward. I mean the staff nurse on the ward. So somehow the patient, before discharge, she didn't mention that he have the catheter with him.
You
And
mean
nobody
this is the Branula?
Yeah, Planula, yes.
The plastic. He went home with the Branula.
Yeah, the green color Planula. So no, the plastic part in, I mean, the transparent part, yeah,
Uh-huh.
was dislodged.
You know, last time when we were young, our grandmother or whatever always said that you can put in a needle and then you will die from it. If you put a needle into under your skin, eventually you will die from it. This is exactly it.
I think that this patient, he want to keep the Planula for the injection of the drug use lah. He want, so it's like
Oh,
easy for him lah. Yeah,
so he is a drug user.
yeah, drug user. Yeah,
Oh, the IVDU is a intravenous
intravenous
drug
drug user.
user.
Yeah.
Okay, I forgot that term already.
So he didn't mention to anybody he had the catheter with him. So he was discharged and found it after 1 month.
Oh, this
So
is very common because when I was a medical student, I used to work in KL General Hospital, and then they will come in, and then we will find no lines. We will put in a central line, you know. Wow, it's like heaven to them. Put in the central line. The moment they put in the central line, they will run away. Okay. I see. Oh my God. So it's also part of his habit lah. I think this is not iatrogenic so much. It's it's carelessness on our side, and also maybe he cheated lah. Maybe he AOR discharge. Okay. Oh, interesting. So this one I'm not so scared. Okay.
okay. So another case of the anaphylaxis. So 5 years old boy admitted for acute exacerbation of bronchial asthma. So during the MO round, he started the IV roxapine to cover pneumonia. So after the specialist round, he decided to discharge the patient. So around like 12 o'clock, so suddenly the staff nurse remember, okay, there's the doctor order the roxapine. So however, the patient already changed the clothes, everything, and waiting for the staff nurse to remove the Planula. So he just, how to say, inject the roxapine into the patient and remove the Planula. So within 5 minutes, this 5 years old boy collapsed and I able to revive. So after postmortem, we proved that there's anaphylactic reaction. Yeah, happened to this
What?
kid. Yeah.
Okay. So firstly, was the roxapine needed because was he really a pneumonia or just a bronchial asthma? You need to ask that. If the total white was not high, maybe he was just admitted for acute exacerbation of bronchial asthma, the roxapine was not necessary. 2 is, was there ever a history of allergy before? And why was IV roxapine given and the boy actually can go home?
Yes, this is the
There's so many questions.
Yeah.
I just don't understand the flow of thoughts in this. Okay, when you manage a patient, there must be a reason for you
Sorry,
to
I
do
think
certain
I'm
things.
interrupted on the internet again.
Is it me or you?
I don't know. Yeah, I can hear you now. Yeah.
Okay, so I mean, for all the practicing junior doctors out there, there must be a reason for you to do things. You must be committed to your diagnosis. If the diagnosis is acute exacerbation of bronchial asthma, your next question is it due to a upper respiratory tract infection or lower respiratory tract infection, or is there any infection at all? And if there is a lower respiratory tract infection, which is pneumonia, why then discharge the patient? Wow, okay. So the boy, poor boy. Okay, let's go on. If not, a lot of people will be able to track these cases down and sue.
Yeah.
Okay, let's go on.
So another case, this is more fascinating case for me lah. Okay,
Okay.
this a
Oh,
postpartum lady with jaundice and liver failures. So he was admitted to the tertiary hospital, and they decided to proceed with the ultrasound guided liver biopsy. So it was conducted under the radio and the medical team with the presence of the medical officer or radiology department and one consultant and two trainee for two trainee for the subspecialty. Yeah. Okay. So okay, four doctors in front of the monitor. Okay. So after the procedure, the patient succumbed to death around 12 hours. Okay. The cause of death is related with the puncture wound or the spleen. Why they intend to take the liver biopsy? How they puncture the spleen? So in this particular patient, she has the situs inversus. So what is situs inversus? Means that all the organ is a mirror image in the opposite direction. Yeah, opposite side. So the how they say, the liver is on the left side, the spleen is over the right side. So everything terbalik lah. Okay. So right now when we go back to the medical record, she had the second pregnancy in this particular hospital, and the situs inversus were diagnosed. So she came back for the third pregnancy and delivered in this particular hospital again, but they didn't go through their own note. Yeah, so they mixed the situs inversus. Okay, first. Okay, second, they did mention echocardio show no destrocardio. This is conducted by the post-basic MA. Yeah, for example, the postmortem show destrocardia. Don't know who is lying about this. Okay, fine. Okay, so throughout the admission, everyone noticed the ECG is abnormal. So because the the
it's
heart is
it's on the right hand side.
yeah. Then another thing, so you have four daughters in front of the ultrasound machine. So the architecture of the liver and spleen, it look similar under the ultrasound examination? So I'm not the expert, so just like if you put the plot, I think one organ is quite big, another one is quite small lah. So yeah, so how they can mix?
Okay, so firstly, the ultrasound must have been done, okay, because she has liver failure and jaundice. So that must have been already done before the need for biopsy, right?
Yeah,
Because you need to do an ultrasound abdomen to come to a diagnosis. Okay. During the ultrasound, was there an ultrasound report whatsoever before the biopsy was taken? Is there no mention of, is that, is that why they say she had liver failure? Because they saw the spleen and it doesn't look like liver. Is that the reason? They saw the spleen. It's not the normal architecture of the normal structure of the liver. So they make a diagnosis that is liver failure. Is that the reason? Okay. We don't even have to look at the ECG or the echo because her symptom is jaundice. Her symptom is jaundice. So everything should have concentrated on the abdomen. And when you concentrate on the abdomen, the first thing that you do for a jaundice person is to do an ultrasound abdomen to see whether there's, gallstones that is impacted in the what, bile duct, anything at all. But so the fact is that the ultrasound, who did the ultrasound, didn't even notice that she has situs inversus. My God. This is not just negligence, this is a crime. Postpartum was the lady's biopsy taken under ultrasound guidance. Yes. It was taken under ultrasound guidance, right?
Yes.
Yes, with 4 doctors on looking. And they hit the spleen because the spleen is where it's meant to be. Wow, shocking. Okay, go on.
Okay. So we can't blame the patient to have the abnormal location of the organ, but we have to blame ourselves because the consent was taken for liver biopsy. So we need to make sure the liver is over the right side. We cannot assume the liver is on the right side. Yeah.
Okay.
Okay. Mm.
Okay, somebody mentioned, Bonsa mentioned that rocephin should be given as an intravenous infusion over 30 minutes. Yes, true. I think rocephin looks a bit cloudy one, right? I used to give a lot of IV rocephin as a house officer in University Hospital, but I can't remember anymore. Okay, we go on before we take all the comments.
Okay.
Okay.
So just a few words about medical negligence. Okay. When this actual injury happen, it doesn't mean that the medical doctor is wrong. Okay. So in law, whether the injury is iatrogenic or not, uh, they're not concerned so much about it. So what the lawyer cares about the negligence. Okay. So as long as the doctor treat the patient with reasonable care, the doctor has not committed a legal wrong, even if the doctor inflicted iatrogenic injury. Yeah. Okay. So another thing, how we decide this is a medical negligence. So first, present the evidence or assistant the duty of care. So means that, for example, you are on call or you are in charge, the doctor in charge of the ward. So you had the duty of care for the patient. And breach of duty. For example, you didn't answer your call, you didn't follow your guideline to manage your patient, and this breach of duty causing injury. So present of these 3 components, and so is potential to be charged as negligent. Okay, if you are inside the airplane, so you are not on call, you go for your holiday, suddenly there's a patient collapse inside the airplane. So in this particular case, either the patient die, okay, in front of you, but you don't have the duty of care for this particular patient. So without the first component, assistant or duty of care, so actually you are not guilty for negligence. Okay. So the legal standard, I think you all have the presentation before. Just a few words. Okay. Previously, they used the Boran test. Okay. So it means that a doctor is not guilty or negligent if they act according to the practice or acceptable standard. Okay. By the responsible body. Okay, for example, it's a cardiac. Okay, the cardiac teams or all the experts they sit down and they say, oh, these complications are not preventable. Okay, so this particular doctor is not wrong. Okay, this is Bolang test. Okay, so the judge of right to follow. So later on, they move on to the Politor test. So the judge is permitted to choose. Okay, so when there's a conflict expert or opinions. So for example, a medical doctor who caused the injury of the patient. So he called a friend who is an expert in the field and testify in the court and saying that, okay, he is not wrong. So uh, by Borang test, okay, so the judge of right to follow because he's the medical professional. He is not, the judge is not, so he had to follow the opinions. So now for the Politor test, he give the chance for the judge to decide, okay, whether to accept the opinions of this particular doctors. Okay, so now move on to the Montgomery test already. So we are no more doctor centered. Now we are more favor to the patient. Okay, so a doctor is under the duty to take reasonable care to ensure the patient is aware of any material risk. Okay, so what does that mean? We are moving forward from reasonable doctor to a reasonable patient. Okay, so um, previously the Boram and the Politor test rely on the peer reviews or what the physician-centric approach to the legal determination of medical negligence. However, now we move on to the patient-centrics. So we need to allow the patient, the reasonable patient, to be informed and to allow them to make a reasonable decisions whether to consent for certain procedure. Okay. Now we are moving on to the
I think
reasonable
before
patient. Yeah,
I
patient.
think before we even discuss this, okay, we need to look seriously in how we are training our junior doctors. Before we even, can you hear me? Even before we talk about this, medical legal concept of whatever, we need to go back and see in every single case of it that they are done by the junior doctors. They are not supervised. And when they were supervised, like the one that they had punctured the spleen, 4 doctors could not pick up a point that it is the spleen. I am sure I can tell a spleen from a liver on ultrasound. I am sure, even though I'm a cardiologist, you know. So I think really honestly, before we go to anything else, we really need to go back to this training, yeah, for everyone. And it's everybody's responsibility, everybody's, from the consultant to the university to everyone. It is shocking. Sorry, I'm going to send this form. So maybe we can take the question regarding your cases first. Okay. Dr. Aswatif Hasni from Dokwiti asks, the doctor actually punctured the heart instead. So the answer is yes. You're right. And then Dr. Ng said, in an emergency situation, plunging a needle into the chest to relieve tension pneumothorax is life-threatening. Okay, what evidence do you have to say for that, Dr. Ng? Because Dr. Tan has just said that a study in 2001 showed that, okay, plunging a needle into the chest to relieve tension pneumothorax does not work. Okay, does not work. And I believe so because the needle is so small, it just cannot release enough. Maybe you can show us the picture again. It will not. Okay. Now, let's say you're in a war zone. You cannot make a diagnosis. You can make a diagnosis of tension pneumothorax, possible, but you cannot do an X-ray. You cannot do a chest tube. Then I can say, okay, do this. But you are in a hospital setting, a tertiary hospital setting, right, Dr. Tan?
Yes.
Yes. Okay. You have not even gotten a chest X-ray to prove that it's tension pneumothorax. Patient is not in any way compromised. Okay. You do this, who's going to cover you? No one can cover you medical legally. Right. Okay. So Dr. Aswatif asked, postmortem lady was liver biopsy done under ultrasound guidance? Yes. And then we just mentioned that Rosaphine should be given intravenous infusion over 30 minutes if preference. I think that Bonza, that is a very good comment. But then again, in anaphylactic shock, it can be sudden, immediate, and even, but it's more likely dose related. But, you know, again, we go back to that case. We just don't talk about anaphylactic shock because we didn't know that the child whether had any history of allergy, but we question the doctor's thoughts, as in their the management in ordering Rosaphine in acute exacerbation, and then discharging the patient at the same time, and then insisting that the nurse give the Rosaphine before the patient is discharged, is just completely mind-boggling. Can Serena ask, liver ultrasound different from spleen? Mistaken spleen from liver? The right kidney, I don't understand this question. Do you understand this question, Tan? Liver ultrasound different from spleen. Yes, liver looks very different from spleen. Very different. The absence of normal position in the right kidney. Well, the right kidney and the left kidney, if the right kidney is not there, the left kidney is there. So kidney is difficult to say. Dr. Swaran asked, Dr. Tan, in your first case for cardiac tamponade, was there evidence of pulsus paradoxus? Point of care. Oh, I don't know what's a POCUS. Okay, so in echo, right, there are some characteristic that you can do to see whether it's a cardiac tamponade, some of which I've mentioned. Some of it needs more technicality. But I don't think there is anything stated on the echo, right? It was not stated that there was an echo, but the pericardial synthesis was done under ultrasound guided. True or not? So this is
Yes.
an echo lah. But if it's ultrasound guided, it must be an echo and ultrasound guided. It can be an ultrasound machine, but then I'm not sure. We need, okay, so it's the next thing is, it is very important that we do everything well documented. Without documentation, it's impossible. Don't jump into conclusion. Okay, the chest is intention. When you plunge a needle, okay, true, but in emergency setting, yes, but not in a clinical setup. You don't just punch a needle anywhere. Okay. So any of your doctors were in charge, were they called for any inquiry? Was there a post-mortem for all this? I mean, not post-mortem on the patient, but post-mortem of the doctors.
Okay. Some of the case, I think the case I mentioned just now, I think 2 cases were charged in the court. So
Cases were charged in court. As
yeah,
a criminal case.
no, and the family lost a
Okay,
civil lawsuit against the
so
doctor.
medical legal case, not a
Yeah,
criminal case. Okay.
yeah. So then, most of the case, sorry to say, the patient is not so educated. So actually, she's so sad that they believe whatever that
We
we
say
we say. That's why they. So I how to say, I won't purposely trigger the
yes.
family to go against the hospital, but what I would say, what is my findings. So because they are not educated, so they didn't, how to say, think of
To bring a case forward, yeah. Okay.
yeah.
Is there any label at the front of the case note for the situs inversus case? I think this is a good idea. Just like sometimes at the case note we put allergies, we should put like situs inversus. I think it's a good idea. I mean, it doesn't strike people, but okay. What are the learning point of this talk? One, learn from these cases. Learn how to do procedure correctly. Correct. Learn to do procedure correctly. Not sure, ask. Okay. Train your fellow colleagues well. In the case of postpartum lady, is it possible for spleen hepatization to occur? This thus misleading. What does that mean? Spleen hepatization. I sorry, I don't know what's the word. what does that mean? Okay. But whatever it is, the spleen does not look like liver, right? Okay, it's been very, very interesting, this thing. I think, do you have more cases next time we can talk about?
Okay.
Okay, I'm going to actually delete this from the Facebook. One is because patients may come forward.
Ah,
Two is
sure.
also because there are some pictures of the post-mortem which I do not want to get blocked from Facebook. But I will add it into YouTube. You all can watch from there. I will share it later. Because my viewership in YouTube is very few, so I'm not so worried. So I think it's been a very good learning process of how, as doctors, people think that we save life, and this is a true demonstration of how we took away life, how we, in our hands, just took away lives. It's just heartbreaking. So I think with that, we end this session. Can we bring you back to do more cases like this? To show us other things lah, don't have to be doctor's mistake.
Okay.
The pediatric cases, yeah, doctor's mistake is also good. It's not like we want to, you know, you see, we did such an interesting case that we really demonstrated to everyone how little training some of our junior doctors have. Sometimes it's no fault of theirs, okay? Sometimes they're under so much stress, okay? They must be taught the right way. Okay, so the take-home message is that we should think before we do. We should do no harm to patients. Our number one, no harm to patients, okay? As junior doctors, even no matter how scared you are, ask your seniors, okay? Try to read up as much as you can, even if there's no one teaching you. YouTube is also a good way to learn. I heard somebody became a dentist just by watching YouTube. So, okay. Next week, I think next week we do have a talk. Oh, next week is a medical legal talk. So join us, okay? So a follow-up from this, we go to medical legal. Okay, sorry, I have to cut you off somewhere because we were running late and we have so many questions. And I really think that we had a very interesting topic today. Yeah, it's an eye-opener. Okay, bye. Every week eye-opener, but my eyes still very small. Bye, guys. Okay, I'm stop streaming now. And I stop